Good afternoon, dear attendees. Now we are starting our session. The title of the session, What is New in Arterial Hypertension? Treatment and Diagnostic in Different Asian Countries. I'm happy to chair this session with Dr. Yaking Zhang from Hawaii Hospital. And the first topic will be presented by Yuking Zhang, management of obesity-related hypertension. Professor Zhang, please, you are welcome. The floor is yours.
Thank you, Kenneth, for your kind introduction. Also want to thank the organizer for inviting me to attend this Asian meeting. I'm very pleased to give these topics on the theme of the obesity-related hypertension and its management. Because currently we are facing a very big pandemic. The problem is the sorry, this is not the right slides, and I'll have to change another one. So there's currently the big situation in our region that we have now facing a big problem of the management of obesity and hypertension, because in China now we have more than 50% of the populations are obese or overweight, and many of them have developed the hypertension. And recent published a paper from the Lancet showing that the new definitions of clinical obesity. So it's not only a risk factor to some extent, it's a kind of disease related to cardiovascular system. So it's a multi-field problem. So not only related to central nerve system, respiratory system, and also affect the metabolism of our body. And also we know that the liver and renal disease also have a lot of patients have this kind of problem in obese subjects. I think the most important today for us as cardiologists, we face big challenges in reducing the cardiovascular disorders, which has still the number one killer worldwide. And consequently, we face up to the upstream problem of obesity and its related problems of arterial hypertension. In 2024, the Chinese government, the National Health Commission of our country, issued a guideline in the management of obesity. And I'm responsible for the drafting the cardiovascular part in these guidelines. And also, one of the important issues is about the treatment of hypertension and other cardiovascular diseases in obese subjects. According to the recent survey on hypertension, we have found that the increase of the body weight index is correlated closely with the development, the higher incidence, higher prevalence of hypertension in our country. Maybe in the 1980s or 1990s, the obesity problem is not serious at that time, but in the 21st century, it's becoming a very big problem, a bigger problem than before. That's something we have to overcome and face up to in the management of hypertension. So not only the aging is not only because of the aging problem and high salt intake, but also the increased obesity problem is becoming more serious in the patients of hypertension. More and more patients with obesity have resistant hypertension. That's something we have to face up to. As the obesity hypertension is a multi-organ problem because it affects the sympathetic nervous system and the mechanism on the natriuretic peptides problem, and sodium absorption, and the problem developed in the renal disease, renal function, and also many other organs have been affected. And many of these have the problem of the increase the incidence of hypertension. So in the intervention of obesity, hypertension, not only lifestyle modification and the traditional antihypertensive agents may be useful in the reduction of the blood pressure, but still not very effective. So we need some more new agents now. So nowadays in clinical practice, with new more mineralocorticoid blockade seems to be promising, and also we have to treat the disease itself by itself by the reduction of body weight. It's a kind of effective way, but at all times we do not have any many choices to treat the obesity patients, because only some anti-obesity agents only available at that time have very high side effects, which cannot be used widely. But in nowadays clinical practice, we have more potent agents, which also safer than before. And also bariatric surgery treatment has become more available and more safer than before. And in some patients, we have to receive this kind of surgical treatment, which is also very effective. So in the pathogenesis of hypertension in patients' obesity, one of the things we have omitted before is that the non-alcoholic fatty liver disease, it actually the MAFOD have also play an important role in the development of hypertension in obese subjects. This is not only have the indirect effect in affecting increase the blood pressure, but also have the direct effect in the increase the systolic blood pressure and diastolic blood pressure in patients with obesity. So the treatment, the MAFOD itself is becoming a more important focus way in the management of hypertension, especially in patients with the obesity. So in the Chinese hypertension guideline that we published last year, we emphasize that the importance of the management of obesity, because actually obesity is the most commonly associated with the hypertension, followed by diabetes. So that's the current situation in the in Chinese population. But also the in the patients of hypertension with obesity, the patient often require more medications to control the blood pressure, and may exhibit a higher rate of resistant hypertension, masked hypertension, and isolated diastolic hypertension, which is more prevalent in patients with obesity, especially in younger age subjects. We can see that the effective management of weight loss is an effective way in the management in the reduction of blood pressure, because if we reduce the blood pressure by 5%, it can show the effect of reduction in lowering blood pressure around 2 to 3 millimeter mercury for systolic. And also, if we have, you can reduce the body weight by 10% or more, maybe a 6 millimeter mercury reduction can be found in the control of the blood pressure, especially in the systolic blood pressure. And also, this is can be achieved by lifestyle modification. We did a meta-analysis 2 years ago, and we can find that if we can lower blood pressure, lower BMI, body mass index by 10%, which is around 2.2 kilograms per square meters, we can find that blood pressure, systolic blood pressure, can be reduced by 6 mmHg, and with the diastolic blood pressure lowered by 3 mmHg. And if we lower the more blood pressure, even the ABPM can also be effectively reduced by 6 to 7 millimeter mercury, which is similar to the current treatment of renal denervation treatment in patients with resistant hypertension. And even the nighttime blood pressure can be effectively lowered by the reduction of body mass index. So the lifestyle modifications are even also effective in the management of resistant hypertension. But the problem is that the perseverance. Many patients cannot persistently to control their blood pressure by lifestyle modification because you have to keep on diet and also do intensive exercise that can so the patient cannot be very well follow the guidelines, so the lifestyle modification guidelines. So that's the current situation. So many times we have to depend on the drug treatment. Many years ago, the pharmaceutical companies developed many agents reducing the obesity, which also shown effective way in reduction of blood pressure. But the side effect is the big problem. So maybe in the 10 years ago, around the GLP-1 agonist, GLP-1 agonist is developed for the treatment of obesity as well as the diabetes, which shown effective, very effective in lowering blood pressure. So maybe 6 years ago, there's a paper published in the Diabetes, Obesity, Metabolism showing that with their liraglutide also have some effective in lowering blood pressure, even in ambulatory blood pressure can be effective in patients of type 2 diabetes and hypertension, lowered by around 6 millimeter mercury, ambulatory blood pressure, diastolic, systolic blood pressure, and around 2 millimeter mercury in diastolic, though not very potent, but anyway, it has shown this kind of agents is effective way in lowering blood pressure. And even the SGLT2 inhibitors that also show the effective in lowering blood pressure in 24-hour systolic blood pressure and diastolic blood pressure, and especially shown the very potent effect in lowering the nighttime blood pressure. So many doctors now in nowadays clinical practice, they would treat patients with diabetes and hypertension using the SGLT2 inhibitor and the GLP-1 agonist also, or both, can be we can see very effective in effect in lowering blood pressure in patients with obesity and diabetes. So and also the long-acting GLP-1 agonist, semaglutide, but it's now those are still using these agents in patients with obesity and overweight, but nevertheless, we can find the effect with the reduction on the body weight. You can find around around 20% of body weight can be reduced by semaglutide. When this at the same time, the blood pressure can also be lowered by 5 millimeter mercury in systolic, and also have checked the effect on the diastolic blood pressure. It seems to be that the diastolic blood pressure can also be significantly reduced by 3 to 4 millimeter mercury. But we still have to remember that the baseline blood pressure in these subjects is around 126 millimeter mercury for systolic and 18 millimeter mercury for diastolic. So it's relatively normal subjects with normal blood pressure subjects. And also in the meta-analysis with the effect of the semaglutide on blood pressure, also find that it's very effective in lowering lowering blood pressure in hypertension, in patients with even in subjects with resistant hypertension, the blood pressure can be lowered by 6 millimeter mercury. and also in patients in all the patients around about seems to be have the similar effects. With the higher blood pressure at baseline, the more effective results can be found in these subjects. So it seems to be practical in patients with obesity. We can use that semaglutide in the management of hypertension, especially in patients with resistant hypertension. This also provide another tool in our clinical practice. Another agent, newer agent, tirzepatide. It's also there are also some data showing that it's effective in the reduce the ABPM in SURMOUNT-1 studies. This is the data we can find that with the higher dosage of tirzepatide, 15 milligrams per day, also shown the effective reduction in lowering ABPM daytime and nighttime compared to placebo. So the blood pressure, at baseline blood pressure is around 124 or 125 mmHg for systolic and 72 mmHg for diastolic blood pressure. And some novel agents with the GLP-1 agonist also now under development. Some pharmaceutical companies use these kind of agents for the treatment of obesity with hypertension. So it's a new area. The sub-analysis from the tirzepatide in SURMOUNT study, it seems that in patients with hypertension or without hypertension, with diabetes or without diabetes, though the effect, the blood pressure lowering effect is relatively similar. Whatever in the elderly or the younger subject or the male or female subjects, in patients with already higher blood pressure, these blood pressure reduction effect is relatively similar, around 6 or 7 mmHg reduction in these subjects favors the newer agent. Actually, in GLP-1 based therapy for the management of resistant hypertension with overweight, obesity, there's some reviews showing that there seems to be some robust data showing that this kind of agent, GLP-1 based treatment, may be very promising, especially in patients with overweight and obesity. So some new agents are now demonstrating even greater blood pressure lowering effects. So with the higher baseline blood pressure, we treat the patients with obesity, and with the obesity treatment lowering effect, it seems to be more effects can be achieved by body weight management. So in obese subjects, blood pressure, body weight reduction per se can bring more beneficial effects in the reduction of blood pressure in patients of hypertension. As for the another tools in the management of obesity and severe patients with obesity, bariatric surgery is an important management in the treatment of this kind of subject, because in patients with very severe obesity, BMI higher than 38 or 40 or more, the GLP-1 agonist or other agents are not quite effective, because most of these agents can only achieve 20% reduction in body weight so as to control their blood pressure, not very effectively. So bariatric surgery have been developed to use in the treatment of even severe obese subjects. There's some analysis showing that this kind of treatment is very effective in the control of the patients with obesity and hypertension. Although we can not find that blood pressure was quite different and significant difference between the two groups, but still can find that the pill burden or the medical treatment can be reduced. The number of agents can be significantly reduced after the bariatric surgery with the similar reduction of the blood pressure with the control group, which means that bariatric surgery is also effective in lowering blood pressure. So with the longer follow-up, we still find the persistent effect on the reduction of blood pressure with the bariatric surgery. So in the recent hypertension guideline in China, we recommend that to reduce the blood pressure to 140/90 mmHg as the initial target in patients with obesity. But if tolerated, target blood pressure can be reduced to less than 130/80 mmHg. So the selection of the hypertensive drugs should be based on the principle of not worsening obesity and metabolic parameters, which means we may favor use the RAS blockade as the initial treatment, then also the diuretics and the beta blocker should be used very cautiously. And also, we also recommend that bariatric surgery can help control blood pressure in patients with severe obesity, and because this kind of treatment can reduce the number of dosage of antihypertensive medications. So this is my presentation. Thank you for your attention. Thank you. You have muted. Okay. Muted. Microphone.
Yeah, okay. Thank you very
Okay.
much, Professor Yu King. It was very interesting topic. I think we can discuss and ask questions at the end of the session. And Professor Yu King, you can present the next presenters.
Thank you, Rakin. Thank you, Rakin. I have the honor to introduce the next speaker, Professor Jiguang Wang, the president of the Chinese Hypertension League. He's from the Shanghai Institute of Hypertension. He is now the director of this institute. He will give the presentation on the topic of 2024 Chinese guidelines for the prevention and treatment of hypertension. And Professor Wang is also the chair of this guideline. Jiguang, please.
Okay, thank you very much, Yuqing, for your introduction. So it's a great pleasure for me to give a short presentation on the 2024 Chinese hypertension guidelines. So as you may see, in the past about 25 years, we published 5 Chinese hypertension guidelines. In the 2024 was the very latest update of this series of guidelines. And it was a teamwork with, you see, many Chinese organizations in the field of hypertension management. Chinese Hypertension League was the organizing organization for these Chinese hypertension guidelines. And here you see some features of this new version of Chinese hypertension guidelines. On the left hand, you see the main criteria for the diagnosis of hypertension and therapeutic treatment of hypertension. And in the middle, you see we listed some new risk factors and also proposed new standards for the definition of various organ damages. And on the right hand, you see the references and some features in the use of Chinese evidence. And here you see the major updates. On the left hand, that's newly added chapters. So we have now altogether 15 chapters, and in the middle, the chapters with extensive updates. On the right hand, that's some revised chapters. So the guideline included more than 700 references. 60% of them actually from the past 5 years, and many of them from the Chinese studies. So here you see the table of contents of these new guidelines, and I would present to you a few major features of these guidelines. We started actually with the epidemiology of hypertension in China. And you see in the past about 60 years, the prevalence of hypertension increased from about 5% to the current close to 30% of adult population. And then if we look at the management of hypertension, we also had quite great achievements in improving the management of hypertension. But in the meantime, we still left close to half of hypertensive patients untreated, and many of them still had uncontrolled blood pressure. You see the control rate of hypertension was still less than 20% of all hypertensive patients. And we proposed the use of both office and out-of-office blood pressure measurement for the definition of hypertension and for therapeutic monitoring. And then we still define hypertension as systolic 140 and diastolic 90 millimeter of mercury, and we further classify hypertension into these 3 stages. And if we use out-of-office blood pressure measurement, we use different criteria. For home blood pressure, 135/85 and higher. For ambulatory blood pressure, 130/80 for 24 hours, 135/85 for the daytime, and 120/70 for nighttime sleeping blood pressure. And here you see the flow of diagnosis, and we of course usually still measure clinic blood pressure if it is higher than 140/90, and we propose to do home or ambulatory blood pressure measurements for the differentiation of white coat hypertension and masked hypertension. And then we continued to use this semi-quantitative risk stratification strategy. We use blood pressure and risk factors, target organ damage, and comorbid diseases and cardiovascular complications to classify into these 4 levels: low, moderate, high, and very high risk of cardiovascular disease. And here you see the new definitions for left ventricular hypertrophy per gender. And so for men, slightly reduced from 25 to 109, and for women actually it was slightly increased from 95 to 105. With these new criteria, and the prevalence of left ventricular hypertrophy in the Chinese population is similar in men and women. If we use the European or American standards, and we will have very high prevalence of left ventricular hypertrophy in women than in men. So we changed according to the recent studies from China. And in these new guidelines, we also proposed this new concept for the management of hypertension. So we do blood pressure control, and in the center of this huge task. But in the meantime, we propose target organ damage assessment, and then based on this assessment, we should treat those patients with target organ damage more intensively and probably with a more appropriate therapeutic strategy. And on the left hand, we also propose the so-called phenotype or mechanisms-driven management of hypertension for the identification of secondary causes of hypertension and also for the differentiation of primary hypertension and between various mechanisms. And here you see the therapeutic strategy, and we propose, of course, everybody lifestyle interventions. And whenever you have a established hypertension, either stage 2 or higher, or high-risk patients with stage 1 hypertension, and they should be treated immediately after the diagnosis. But if a patient with stage 1 hypertension and lower cardiovascular risk, and they may still have a period of time for lifestyle interventions, then antihypertensive drug treatment should be considered if blood pressure is not controlled to the target. In this new Chinese hypertension guidelines, we propose intensive blood pressure lowering. So you see, we recommend 140/90 for most of hypertensive patients, but whenever tolerable, and they should be treated to a level of 130/80. But for those people over 80 years, and we still recommend a less intensive target of blood pressure control, 150/90 or 140/90 and below. And we also proposed therapeutic target for home blood pressure and 24-hour daytime and nighttime ambulatory blood pressures. And we here you see listed various lifestyle interventions, especially on the basis of the recently emerged evidence from the Chinese studies. And in the recommendations on antihypertensive drugs. Here on the left hand, we proposed 6 classes of primary agents, including the newly recommended angiotensin receptor neprilysin inhibitors. And this drug was approved for the management of hypertension in China and several other Asian countries. And here in this new Chinese hypertension guideline, we clearly recommended this new class of drugs for the treatment of hypertension. On the right hand, we also recommended some other classes of drugs for the treatment of resistant hypertension or for difficult to control hypertension with some special characteristics. And for the combination therapy of treatment, of antihypertensive drugs, and we recommended more appropriate or optimally optimal combination regimens, especially with honey, with angiotensin receptor neprilysin inhibitor, in combination with the hydrochloride calcium channel blockers or thiazide diuretics. And we, of course, strongly recommend the use of combination therapy whenever needed, either for high blood pressure or high cardiovascular risk. You see on the left hand, we kept monotherapy, but we encourage our colleagues to start combination therapy earlier and in more patients. And for the device-based therapy is mainly renal denervation. And we had some pragmatic recommendations on the use of this new technology for the treatment of resistant hypertension or difficult to treat hypertension because of, for instance, intolerability to antihypertensive drugs or a low treatment adherence to antihypertensive medication. So only after the diagnosis of resistant or difficult to control hypertension and exclusion of secondary causes of hypertension, renal denervation can be considered in mainly excellence centers for the treatment of hypertension. And in these new guidelines, for the first time, we also recommended the use of or the appropriate use of traditional Chinese medicine for the management of hypertension. So the condition is very clear. We need evidence from randomized controlled trials to prove both efficacy and safety of any traditional Chinese medicine. So in this, at the end of these new hypertension guidelines, we also recommended listed actually some urgently need to address the research questions. And thank you very much. I hope with these new hypertension guidelines, we would improve the management of hypertension in China in the next few years. Thank you. Thank you very much.
Yes, thank you, Professor Jiguang. So, and the question will be at the end of the session. And next topic goes to Professor Narsingh Verma, who is currently in Chicago, participating at American Diabetes Association Congress, and he very kindly to join us, and he will present the topic of time-restricted eating in relation to cardiovascular effects. Professor Verma, you are welcome.
Thank you, sir. Thank you for giving this opportunity. And I will be talking about the time-restricted meal and time-restricted eating and their effect on the cardiovascular system. So I'm sharing my slides. So I think my slides are visible. Okay.
Yes, visible.
Okay, fine.
Go ahead.
Fine. They're not moving. Why they are not moving? See why they are not moving. Slides are visible or not visible?
Not visible now. Please share it again.
Yes,
Okay,
before
okay,
it was visible.
I will share again. Fine. Yeah. So I will be talking about
Excuse me,
the
Professor Verma, could
time-restricted
you
meal
full
in
screen? Can you
relation.
make full screen? Full screen presentation.
Yeah.
Full screen.
Yeah. Fine. So yeah. So I will be talking about what is TRM and what are the various mechanisms involved and the evidences from the studies and practical considerations and various positive effects of the TRM on cardiovascular health and the mixed or neural effects and then the potential risk or considerations, and then I will conclude my talk. So, before I go further, I will be talking what are the various types of the intermittent fasting, and that includes the TRM as well, time restricted eating. The time restricted eating is the eating pattern involving the restrict food intake to a specific timing, typically between 8 and 12 hours each day. And intermittent fasting is eating pattern involving fasting for varying period of time, typically for 12 hours or longer. And the when we use term calorie restriction, here the time is not important. This eating pattern involves continuous reduction in calorie intake without malnutrition, and here the time is not important. And alternate day fasting is eating pattern involving the consuming no calories on fasting days and alternate fasting days with a day of unrestricted food intake or a feast day. So feast and then fast, feast and then fast. And alternate the modified fasting includes the eating pattern involving consumption of less than 25% of baseline energy needs on fasting days, alternated with a day of unrestricted food intake or a feast day. Here is a little difference that the only on the fast day calorie intake is very less. Periodic fasting is another term where the eating pattern consists of fasting only 1 to 2 days per week and consuming food and ad libitum on 5 to 6 days per week. So these are the different type of pattern of eating which are being used. I have particularly worked in the area of TRM, so I will talk more about time restricted meal or time restricted eating. When we take time restricted eating, then the effect is seen on the various parts of the body. In brain, it improves the cognition and the neurotropic factor production, and the synaptic plasticity is improved, and the mitochondrial biogenesis changes, and the resistance to injury and disease has been observed. An effect on the blood system is seen in the form of elevated ketone levels. Ketone bodies are more in number and reduced glucose, insulin, and leptin levels. There has been seen elevated adiponectin levels, reduced inflammatory markers like cytokines, and reduced markers of the oxidative stress. And in the cardiovascular system, the reduced blood pressure has been noted, and reduced resting heart rate has been noted, and increased parasympathetic tone and stress resistance has also been noted. Similarly, liver, we can have seen the effect in the form of glycogen depletion and the ketone production and the increased insulin sensitivity and reduced lipid accumulation. In the adipose tissues, lipolysis reduced leptin production and reduced inflammation. While in the intestine, GI tract, the enhanced motility of GI tract and reduced inflammation has been noticed. In the muscles, increased insulin sensitivity, enhanced efficiency, endurance, and reduced inflammation has been noted. So these are the effects which have been noted by TRM, time restricted meal. This time restricted meal can also be of various types. Here, usually during night time, meal is denied, and during daytime, there is a window of taking meal. And this window, if the window is very small, then only the desired effects are seen. If window is large, then the effects are not seen up to its level. So, positive effect of time-restricted meal intake on cardiovascular health. If we talk more, it improves the blood pressure, and it can lower systolic and diastolic blood pressure by reducing insulin resistance and improving vascular function. So, all the changes are occurred at vascular level. Studies show the reduction of 3 to 10 millimeter mercury in systolic blood pressure, and in obese individuals 8 to 12 weeks of TRE. And it has also shown the better lipid profile levels. The total cholesterol levels are reduced, LDL is reduced, and triglycerides are also reduced. And they have been seen to slightly increased HDL cholesterol levels as well. This is likely due to enhanced fat metabolism during fasting periods. And there has also been noticed the reduced inflammation. The markers of inflammation have been studied like the CRP and interleukin 6, which are linked to the atherosclerosis and heart disease risk. They have been reduced. There is also improved insulin sensitivity by enhancing glucose metabolism. TRE reduces insulin level and improves insulin sensitivity, lowering the risk of type 2 diabetes, a major cardiovascular risk factor. So, the cardiovascular system is also affected by improving the type 2 diabetes. So, when diabetes risk goes down, the vascular effects are definitely seen. Weight loss and fat reduction. TRE promotes modest weight loss, 1 to 4% of body weight is visceral fat, which is associated with a lower cardiovascular risk. And there has been enhanced heart rate variability. HRV is good, and if it is more, these studies have suggested that TRE improves HRV, indicating better autonomic nervous system regulation and cardiovascular resilience. So, these are the effects which have been seen. Mixed or neutral effects, if we talk about, there no consistent effect on heart rate has been noticed for long-term studies. Most studies show minimal change in resting heart rate with TRE and only initial levels, then it comes back again. Variable impact on HDL. While some trials support the stable or increased HDL, others show no significant change in HDL. So there are different type of study available, and the conclusion is still to be drawn. I will throw more light on that in my coming topic. The potential risk or considerations are also there. When TR is done for a long time, there are some risks involved which had to be taken in account. They are like nutrient deficiency risk. If meals are not well balanced, potential affecting long-term cardiovascular health can also be seen. And it is not suitable for all. Everybody cannot do it, and it should be done under medical supervision, and without consulting doctor, it should not be done, because sometime it can even the harm cardiovascular system. The long-term data of TRM are missing. Most studies have been done are short-term studies, 8 to 12 weeks. In my laboratory, again, it has been done only for 6 months. More than that, the studies are still missing, and we need data for long-term studies. In one of my study in the laboratory, we have done for 2 years, and we have seen that the effect of TRM vanishes or is reduced when it is done for more period. And there is also risk of overeating. Some individuals may overconsume calorie dense unhealthy food during the eating window. So when window is less, then they try to consume more calorie dense food. Mechanisms, what are the mechanisms involved by which we say that the and TRM is having good effect on cardiovascular health. The possible mechanisms which have been studied are autophagy and cellular repair. Fasting period may enhance autophagy, reducing oxidative stress and improving endothelial function. Circadian rhythm alignment is one of another mechanism. We know that normally all body physiological mechanisms are having a circadian rhythm. And usually, the circadian rhythm is maintained in such a manner that the central clock at the suprachiasmatic nucleus and peripheral clocks at other parts of the body, like the liver, fat cells, and the muscle, they are peripheral clocks. Usually, what is happening that peripheral clocks are following the central clock, or they are aligned to the central clock. This is called as synchronized circadian rhythm. But when the peripheral clocks are not following the central clock, maybe because of our faulty lifestyle, then the circadian rhythm alignment is lost, and this is called as desynchrony. And this desynchrony is responsible for most of the metabolic diseases, including the cardiovascular diseases. When this desynchrony can is be corrected and is corrected to resynchrony, and this circadian rhythm alignment can be done by the TRM. TRM helps in resynchronization the central and peripheral clock. Ketone production is another mechanism where the extended fasting periods increase ketone production, which may have anti-inflammatory and cardioprotective effect. We all will agree that in SGL2 inhibitors, again, these ketone bodies are important. So the TRM has some similar mechanisms which SGLT2 inhibitors are having. So you can say by using TRM, we are naturally taking SGL inhibitors. Intermittent fasting strategies and their effect on body weight and cardiometabolic risk factor. This is a systematic review and network meta-analysis of randomized clinical trials. Up to 2025, the various trials have been included. And this has been done by Semani Azad et al. And published in BMJ in 2025. Here, the 99 randomized clinical trials involving 6,582 adults of varying health conditions have been included. All intermittent fasting and continuous energy restriction diet tested body weight. They found that body weight is reduced when compared with ad libitum diet. And alternate day fasting showed a trivial reduction in body weight compared with both time restricted eating and whole day fasting. So, weight reduction is definitely there, and this weight reduction may be in the tune of 1 to 2 kg. What we have observed in our laboratory, this weight reduction is more in beginning, and in first month, 2 months, 3 months, this weight reduction is not that much, and weight stabilizes to its that level. Key findings have been shown in this particular research shows that alternate day fasting lowered total cholesterol, triglyceride, and non-high dose lipoprotein compared with time restricted eating. Weight loss, which I said is a constant feature, and a 10-hour window, 12-hour window that has produced the body weight reduction, and that is significant body weight reduction has been seen. Blood pressure lowering has also been used, and that is significant, statistically significant, and p-value was found 0.01, and systolic P was reduced in the tune of 3 to 6 millimeter mercury, and diastolic 2 to 4 millimeter of mercury. Intermittent fasting strategies and their effects on body weight and cardiovascular risk factor. Again, a systematic network meta-analysis of randomized clinical trials that has been shown that the trials have shown that the weight is and after that the glucose and insulin have also been studied and found that TRE improves resting glucose, and also the insulin sensitivity is improved, home been studied. And lipid levels have also been corrected, the lowering triglyceride levels, and the also change in the LDL levels have been noticed. Cardiometabolic risk is reduced by applying the intermittent fasting or the TRM. And here the Framingham risk score was used, and that has been found that p-value is 0.91. So we can say that TRM reduces cardiovascular risk. The adherence rate has also been found good. Those patients who do this TRM, they have good adherence rate, and those who are not following, they definitely do not have it. Intermittent fasting and cardiovascular disease, a scoping review of the evidence 2024. Here the study design was the scoping review of human and animal studies on intermittent fasting, and including TRE, ADF, and intermittent energy restriction. Here the participants were focused on human trials. 20 studies were included, 1,000 participants with obesity, metabolic syndrome, or post-myocardial infarction. Intervention was done in the form of 4 to 8 hour windows, ADF and IR compared to usual diets. Outcome measured were the cardiovascular risk factors, cardiac remodeling, and CVT mortality. The key findings show that the TRE reduced body weight 1 to 3%, blood pressure 3 to 6 millimeter mercury, and fasting glucose 2 to 5 milligram per deciliter in obese individuals. P-value was found significant. Post-MI trial showed improved left ventricular function and reduced cardiac remodeling with the TRE. Again, p-value was 0.05. Intermittent fasting reduced inflammation as well. IL-6 level were significantly lower, and oxidative stress markers were like the isoprotein. The again 0.02 p-value was found. So implications, if we say, the review advocates for personalized approaches, especially for CVD patients, and more RCTs to quantify long-term risk and good effects. And contrasting evidences suggest short-term benefits are robust, but long-term safety is uncertain. So short-term benefits, every research has shown robust, but the long-term safety is still a concern. Our long-term effects are still required, and we require long-term data to say that. I will show some long-term data in my presentation as well. Cardiovascular benefit of TRE, short-term clinical trials have shown the improved markers in the form of, and here the window was 4 to 12 hours. And here I will like to specify the shorter window has good effect and has been shown to reduce fasting insulin, blood glucose, total cholesterol, LDL, and systolic blood pressure. Lot of studies have been done, and Moon et al. 2023, and these are published in Frontiers in Nutrition and meta-analysis of 26 clinical trials. Eating window timing is very important. Early TRE, first meal before 10:30 a.m. is more effective for reducing blood pressure and improving insulin sensitivity than late TRE. And the shorter window has been found more efficacious. This study was done by Liu et al. And published in Clinical Nutrition, meta-analyzing, comparing early versus late TRE. Evidence of the benefit of time-restricted meal from my own lab. We have done this study in the KGMC, and here in endocrinology department, the patient were recruited, and from Lari cardiology, which were having the cardiovascular patient, they were recruited. In this randomized trial among patients with diabetes, follow-up after 12 months revealed that 65% of TRM group and 40% of non-TRM group had normal A1C. So the AC normalization was more in TRM group. The in TRM group had a significant p-value of 0.017 in comparison to the other group. Highly significant results were obtained in the cases of fasting and postprandial values of blood sugar in TRM group. So patient aged between 25 and 60 were chosen, and they were having diabetes from last 5 years and having high cardiovascular risk. And they were receiving oral anti-diabetic treatment like metformin, sulfonylurea, or gliptin, SGLT2 inhibitors, gitazones, etc. And they were not receiving insulin. Patient reporting with diabetes other than type 2 diabetes mellitus were not included in this particular study. A single intervention was all that was done in the TRM group, which was that dinner time was kept at 7 p.m. So the window of meal was reduced, and they were taking between 9 to 6. 9 to 6, meaning by only 9 hours, 9 to 10-hour window was there. The dinner time in the control group was any time after 7 p.m. Normal Indian diet of pulses, chapati, etc. was continued. So we never had any change in the type and quantity of diet. Only time was included in the study. And the study design, as shown here, the TRM group and the control group, they were compared, and the standard convention treatment was similar in both. Only intervention was TRM, and they were assessed in thrice after every 6 months. Every 6 month assessment was done. So we followed them for more than 2 hours, 2 years, and the the study shows the results, which were the in the same line that the weight was reduced, and their anthropometry was also changed up to some extent. The neck size, hip, and the waist size were also compared. There were no significant change in weight of the control group in relation to the case in 18 months. Barring a change of HDL, no parameter of lipid profile, total cholesterol, triglycerides, etc., registered a significant change, which we found. In the control group, the BMI, blood sugar fasting, blood sugar postprandial A1C, and HDL has a significant change, and the TRM group waist size, LDL, VLDL did not register a significant change. So we were not able to notice any anthropometric change in our patient. The biggest change was noted in the lipid profile and the parameters of total cholesterol, triglyceride, and HDL were affected maximally. Single intervention we did was the time, and we can say on the basis of our study that the feeding habits misaligned with circadian clock that is responsible for most of the cardiovascular and metabolic diseases, and this is because of night shifting, social jet lag, and the late night eating, which is responsible for circadian clock disruption and increase in the metabolic risk. And that leads to more obesity, more body weight, more fat mass, more food consumption, and the more cardiovascular risk in the form of increased blood pressure, increased LDL, and decreased HDL. And there are more chances of diabetes that again increases the cardiovascular risk. And if the patient is the subjects are taking meal early and then in the shorter window, then the circadian clock alignment is there, and this decreases the metabolic risk. And these patients have less obesity, less cardiovascular risk, and less diabetes. So, the potential long-term risk, although we don't have much data, but there are some data. They show the increased cardiovascular mortality. One such study has been found, and the study using the NHS data, and that was found and between 2003 to 2018. 8-hour eating window was associated with a 91% increased risk of cardiovascular death. This study was contrast to the most of the studies, and risk was higher among individuals with existing heart disease. So this was done and published in 2024 and presenting the in the American Heart Association, and they said that the probably the TRM may not be that safe in the patients who are having high risk of cardiovascular disease. But this was an observational data, and causation established. Confounding variables were there, like pre-existing conditional, like tobacco and other alcohol, and the severe coronary artery disease, and having very high risk of cardiovascular disease was there. So we can have an inference that the we should do this TRM under medical supervision, and this is good for those patients who have less cardiovascular risk and they are not active disease in the severe nature that can hurt. And again, this is similar to what we found in the trials like a car trial, similar to that. If the high risk individuals were included, then the mortality will be more, and this mortality may not be because of the TRM. The circadian studies have shown that circadian alignment and cardiovascular functions, they are interrelated, and they have included HRV, blood pressure, and thrombosis risk markers, and it has been studied that the they are improved endothelial functions and reduced oxidative stress. So the TRM is helpful. It is not increasing the cardiovascular risk. Few more studies have been done. A study of dance sport dancer shows that 16:8 TRF improves body without compromising performance, and suggesting that the preservation of mass is there and decrease in the fat is there. Another pilot study in PO2 POTS patients indicated TRF improves heart rate, mitochondrial function, and quality of life, hinting at broader cardiovascular applications. So we have data which shows that the probably the TRM can help in reducing cardiovascular health if it is done under medical supervision. But still, these all studies are not conclusive, but reflecting ongoing interest in TRE, and we need more robust data to show that yes, it is good. Few more data I'm presenting like this was published in Cell Metabolism. Here, 10-hour time restricted eating reduced weight, blood pressure, and atherosclerosis lipids in patients with metabolic syndrome. And you can see here 10-hour window was used, and body weight, waist circumference, blood pressure, LDL cholesterol, non-HDL cholesterol, the hemoglobin, and the resting restful sleep was studied. And this was published in Cell Metabolism, and this shows very powerful data in relation to TRM. 10-hour window was used. Another study was published in Annals of Internal Medicine. Here, the time restricted eating in adults with metabolic syndrome, and this was a randomized
Sorry,
controlled
nothing.
trial.
You have to take care of the time. It's over time right now.
I will just finish. Yeah. So this is I only 2-3 slides left. So this is one mechanism that the TRM has the preclinical and human studies. We have a lot of studies which can show that. I am just finishing it. And so takeaways are that short-term TRM may improve cardiovascular markers. Early TRM has have the like the breakfast focus, ending meals, and the very narrow eating windows may carry long-term cardiovascular risk, but very narrow eating window are important. Circadian alignment matters, and this had been there. So by this, I will end here, and these were my references. Thank you very much.
Thank you, Nasim, for your very informative lecture, which is very important. Because of the time, we have to move on, and the next speaker, I would like to invite the next speaker, Dr. Samay Abilova, to give the presentation. But I don't know what Dr. Simay, are you here? Hello, Dr. Samay Abilova. Dr. Samay Abilova. Are you here? You're online?
Sorry, excuse me, Professor. So I'm not really sure if Professor Samay is has been online. Maybe he just hang on here. So maybe we can just move on, and I'll let our conference team connect with him.
Okay.
She has a problem with connection.
Sorry, just please move on.
Okay, we have to move on. Maybe next speak. No, I saw the next presentation should be delivered by Professor Yan Li. Is Professor Yan Li now here? So I have not seen him. I cannot see her. The next, next presentation delivered by Professor Yan Li from the Shanghai Institute of Hypertension. Please, Dr. Li.
Dear colleagues and friends, I'm Yan Li from Shanghai Institute of Hypertension. It's my great honor to join this session. But first, I have to apologize that I cannot attend the session in person, and also apologize that my voice might not be very clear because I caught a cold very severe. Anyway, today I would like to introduce and discuss with you on our recent research on time in target range of the 24-hour blood pressure. As you may know that blood pressure varies during our daily life when we were lying down or standing or sitting or exercising or sleeping. Our blood pressure and heart rates changed a lot. So for the definition of hypertension or to assess blood pressure control status, we usually rely on the average of several blood pressure measurements during several days or during the 24-hour or the home blood pressure measurements for several days. However, we also recognize the limitation of the use of blood pressure means to assess blood pressure control status. As you know that the means, we cannot, by use of the means, we cannot address the blood pressure variation. So recently, a new marker, the time in target range, TTR of blood pressure, has emerged as a very attractive marker to assess blood pressure control status. Up to now, there are two ways to calculate the TTR of blood pressure. One is to calculate the percentage of number of BP readings within target among the total number of BP readings. Another way, which is more commonly used, is to calculate the percentage in time duration of blood pressure within target among the total time. In this slide, you can see the schematic diagram for the lower and the higher controlled TTR of SBP. At the left panel, you can see most of the SBP readings were above the target range. So the TTR was low. At the right panel, you can see that most of the SBP readings were within the target range. So the TTR was high. So from these two panels, you can see the lower versus higher TTR. And up to now, there are many prospective studies showed that higher SBP TTR was associated with lower cardiovascular risk. As shown in this Chinese veterans cohort, including more than close to 1,000 participants, averaged age 78 years with a median follow-up of 10 years. And you can see a high SBP TTR of over 75% compared to a low SBP TTR of less than 25%. The higher TTR was associated with a low risk of primary and secondary outcomes by about 60%. So higher TTR, lower cardiovascular risk. And in this famous Chinese Hanzhong adolescent hypertension study, which included 1,637 children with a long-term follow-up, we also observed that higher SBP TTR from childhood to middle life was associated with lower midlife brachial-ankle pulse wave velocity, which is an indicator of arterial stiffness. So higher TTR, better arterial elasticity in middle life. However, all these studies on TTR used office blood pressure measurement. Very few studies addressed the 24-hour ambulatory blood pressure TTR. And we also know that compared to the office blood pressure control, actually the control rates of the 24-hour ambulatory blood pressure were even lower in China. According to our report from the China Registry of Ambulatory Blood Pressure, the reaction ABP study, we know that only 21% of patients had their 24-hour blood pressure controlled. So using our previous cohort data, we recently did some analysis on the 24-hour ABP TTR, and we analyzed the distribution and the determinants of the 24-hour ABPM DDR, and we also explored the predictive value of the 24-hour ABPM TTR, and investigated if there is any added value by the TTR beyond the 24-hour mean SBP level. And we also performed a post-hoc analysis of a clinical trial on mass hypertension and explored the impact of the antihypertensive treatment on TTR and the change of TTR and the association of change of TTR in relation to the target organ damage improvement. So first analysis, we used the data of our China ABPM registry in 10,000 patients, the reaction ABP study. In this study, from 2018 to 2024, more than 6,000 outpatients in 152 hospitals and community health centers were recruited. And this slide shows the distribution of the 24-hour SBP and DPP TTR. And you can see generally 24-hour SBP and the DPP TTR were normally distributed. And this slide shows the 24-hour daytime and nighttime SBP and the DPP TTR mean and the SD. Using two different definitions. So irrespective of the definition of TTR using the percentage of number of readings or the percentage of time of BB within target range, you can see that the mean level of TTR was about 40 to 50% in 24-hour daytime and nighttime, irrespective of the definitions. And this slide shows the 24-hour daytime and nighttime blood pressure levels according to the quartile distribution of the 24-hour SBP TTR. And you can see, as expected, with the increasing level of 24-hour SBP TTR, the 24-hour daytime and nighttime blood pressure level were better controlled, were lower in the higher quartile of 24-hour SBP TTR. And we also observed that with the increasing quartile of the 24-hour SBP TTR, the patient characteristics differed significantly between the quartiles. And you can see that with the increasing quartile of the 24-hour SBP TTI, age and body mass index, glucose level and cholesterol level decreased within the increasing quartile of TTR. And less men and less smokers, drinkers, and patients with diabetes mellitus were included in the higher quartile of 24-hour SBP TTR. And also with the increasing quartile of SBP TTR, we observed that the number of patients using the calcium channel blockers, ARBs, and beta blockers increased. So with the increased number of patients using these antihypertensive drugs, the 24-hour SBP TTR increased. So in the multiple stepwise multiple linear regression analysis, we can see that the 24-hour SBP TTR was influenced by these common cardiovascular risk factors, including age, sex, body mass index, smoking, drinking, glucose, and the cholesterol level, and the use of antihypertensive drugs. So more use of antihypertensive drugs, more favorable metabolic profiles were associated with better or higher 24-hour SBP TTR. So in the next part, we analyze the predictive value of 24-hour ABPM TTR. And in this part of analysis, we use the data of outpatients referred for the 24-hour ABPM in our hypertension clinic Region Hospital. In this study, the 24-hour ABPM was performed by the Mobilograph, a German device. And from the year of 2017 to 2020, more than 20,000 patients were enrolled in this study. And these patients were followed up with a median time of 2.8 years. And within this follow-up, more than 200 all-cause deaths and 78 cardiovascular deaths occurred. And this shows the characteristics of the study population. And you can see, compared to those survived patients, the died patients were older and had unfavorable cardiovascular profiles and higher 24-hour and daytime and nighttime blood pressures. And this Kaplan-Meier analysis shows the risk of all-cause mortality and cardiovascular mortality in relation to the quartile of the 24-hour SPP-TTR. And you can see that with the increasing 24-hour SPP-TTR, the risk of all-cause mortality and cardiovascular mortality decreased. And this was also the case in the multivariate adjustment analysis. You can see with one standard deviation increase in 24-hour SPP-TTR, the risk of all-cause mortality decreased by 16%, and a cardiovascular mortality risk decreased by about 40%. And we also computed the C-index, NRI, net rate classification improvement, and IDI, integrated discrimination improvement indices for all-cause mortality and cardiovascular mortality. We compared the models, the base models, including common cardiovascular risk factors, and the models with the 24-hour SPP level, and the model with the 24-hour SPP-TTR, and the model with both parameters. And we can see that adding the 24-hour SPP and the 24-hour SPP-TTR significantly increased IDI. But we can also see that although the values are statistically significant, the increment in IDI was very small. So it means that the added value of the prediction by the 24-hour SPP-TTI beyond 24-hour mean SPP level was modest. In addition to our single-center study, we also analyzed the predictive value of 24-hour SPP-TTR by using an international collaborative database, the ADCO study. And in this analysis, we used two different ABPM thresholds proposed by the 2018 ESC guideline and the 2024 ESC guideline. We know that the 2018 ESH guideline proposed the non-hypertensive 24-hour ABP of less than 130 over 80 millimeter of mercury, while the 2024 ESC guideline proposed a low threshold of less than 115 over 65 millimeter of mercury as a non-elevated 24-hour ABPM. If we use the different threshold, we can see that the distribution of SPP-TTR were also different. The median was about 60% using the high threshold and 18% using the low threshold. However, irrespective of the different thresholds used, the higher 24-hour SPP-TTR was always associated with lower risk of total mortality and the cardiovascular endpoint. But if we use the different thresholds for the TTR, we can see that the high the 24-hour SPP-TTR using the low thresholds compared to the high threshold where shorten the interval required to reduce relative risk from 60% to 18%, equivalent to about 14 hours of time of target range to 4 hours of TTR. So if we use different threshold, it means the TTR required to reduce relative risk will also different. So in this study, this analysis has been published in recent in the European Heart Journal. And this study once again told us that the 24-hour TTR predicted outcome irrespective of the threshold used. However, the time to reduce the time of BP within target range to reduce cardiovascular risk will be different. So in the last part, I will report to you about our analysis on the impact of antihypertensive treatment on the 24-hour TTR and the improvement of target organ damage. In this analysis, in this post-hoc analysis, we used the data of the anti-mask trial. This trial is a multi-center randomized double-blind placebo-controlled trial on masked hypertension. And this trial compared the effect of active antihypertensive treatment versus placebo on the improvement of target organ damage in patients with masked hypertension. We computed the baseline 24-hour ambulatory blood pressure level and the TTR level. And you can see that in these patients with masked hypertension, the mean 24-hour BP was about 136 over 85 millimeter of mercury. And the mean SBP and DBP TTR was about 40%. And after the 12 months treatment, we can see the active antihypertensive treatment with alisartan and amlodipine significantly decreased the 24-hour SBP and DBP level by about 10 over 6 millimeter of mercury compared to placebo. And also, we observed the 24-hour SBP and DBP TTR significantly decreased by about 20% in the active treatment compared to placebo. This table shows the TTR decrease in 24-hour daytime and nighttime in the active treatment group compared to the placebo group. And we can see that the between group difference was about 15 to 25%, were all statistically significant. And the most important finding of this analysis is that we observed that the TTR increase was associated with target organ damage improvement. And you can see that each 10% increase in the 24-hour daytime, nighttime SBP or DBP TTR was associated about 15 to 25% increase of likelihood of the improvement of target organ damage. So in this analysis, we can conclude that the 24-hour ambulatory blood pressure TTR has some clinical value, and we should do more research on this regard. And from this analysis, we know that the median 24-hour SBP TTR in our treated Chinese hypertensive patients was only 50%. And this SBP TTR can be determined by common cardiovascular risk factors, including age, sex, body mass index, and smoking, drinking, and unfavorable glucose and cholesterol levels, these metabolic abnormalities. And in our prospective analysis, we observed that the 24-hour BPTTR can independently predict all-cause and cardiovascular mortality in hypertensive patients, and it can improve the discrimination of all-cause and cardiovascular mortality, although the incremental predictive value over 24-hour BP by the TTR was modest. And from the third part of post-hoc analysis of our anti-masker trial, we know that antihypertensive drug treatment can improve the 24-hour TTR, and the TTR increase can significantly associated with the improvement of target organ damage. So all these analyses indicate that the 24-hour blood pressure TTR can have some clinical additional clinical value beyond the 24-hour blood pressure mean. So more research is deserved on the 24-hour blood pressure TTR. And these are all what I would like to share with you. Thank you for your attention.
Thank you, Professor Di, for your wonderful presentation. Now I move the chair to Professor Mirakov. Professor.
Yes, thank you very much. And the final presentation is sex differences in arterial hypertension. And Professor Samaya Bila, you are welcome, please. Share your screen.
My presentation is visible?
Yes, visible plus
Видно меня?
full screen, yes, make full screen, okay? Full screen, please. Can you make full screen?
Yeah, just a moment. It's okay?
No. It's just,
No,
yes,
why not?
okay, it's good. Go ahead, please.
Thank you. Dear colleagues, I'm very glad to meet and take part in so important conference. And now we say about sex differences in arterial hypertension. Globally, hypertension affects a significant portion of the adult population with notable sex differences. Men generally have a higher prevalence of hypertension compared to women, particularly in early and middle adulthood. However, this pattern changes with age, and women eventually surpass men in older age groups, indicating the influence of hormonal and physiological changes across the lifespan. If we say about the prevalence of arterial hypertension in my country, in Kyrgyz Republic, you can see that 10 years ago, prevalence was more than 42%. It's about 43%. And now, 2 years ago, was epidemiological investigation stats in 2023, and we can see that the prevalence of arterial hypertension currently 32%, significantly lower than previous study. It was more than 42%. Possible, it's depend on prevalence of behavioral risk factors. Blood pressure patterns change differently in men and women throughout life. Boys and girls begin with similar pressure levels in early childhood, but during puberty, men experience a sharp increase in systolic pressure. Women exhibit a more gradual rise that becomes pronounced after menopause. Hormonal transitions such as puberty, pregnancy, menopause, and andropause significantly influence blood pressure regulation. These life stages cause distinct physiological responses in men and women that contribute to long-term differences in health. Men and women exhibit different profiles of traditional cardiovascular risk factors such as obesity, diabetes, and dyslipidemia, and comorbid conditions. These only influence the prevalence of hypertension, but also in assessment and management approaches. This investigation demonstrates that in the Tehranian population, nearly 2.3 of total participants develop hypertension each year, and obesity and higher blood pressure levels are the main modifiable risk factors in both sexes. Hypertriglyceridemia, prediabetes, and former smoking are risk factors for hypertension among women. Sex differences extend to the damaged hypertension causes of target organs such as the heart, kidney, and brain. Women, especially those who are younger or middle-aged, may have lower baseline blood pressure but are more susceptible to adverse outcomes like acute coronary syndrome once hypertension develops. This underscores the need for earlier and more aggressive management in women at risk. Women have a low blood pressure threshold for developing complication than men. Indicated that for each 10 millimeters mercury increased in systolic blood pressure, increase the CVD risk by 90%. And if we see in subgroup analysis that indicated, this analysis indicated that per 10 millimeters mercury increase in systolic blood pressure, CVD risk increased by 20% for females and 19% for males. So females had a higher CVD risk than males. Women attain higher rates of controlled blood pressure than men do until their 60s, whereafter the situation is reversed and men exhibit better blood pressure control. All drug classes used in hypertension fell off steeply in use after 18, except for beta blockers and MRI in both men and women. You can see that labetalol used in women in age 25-35, which is missing in men, and which can be attributed to its role in treating hypertension in women in pregnancy. If we say about the side effects, we can see that the differences in pharmacokinetics and pharmacodynamics between sexes are well described. Women report side effects more frequently, and we can see that women have hyponatremia, hyperkalemia, arrhythmias with diuretics, and edema with dihydropyridine calcium channel blocks. Cough with use the EC inhibitors. And if we say about men, we can see that more often develop the GOT with use the diuretics and erectile dysfunction with used beta blockers. Thank you for your attention.
Thank you very much for your presentation. So I would like to ask from organizers, do we have a short time for discussion, for questions? I think we have a few minutes. Yes?
Only a few minutes, yes. Yeah.
Anybody has questions? Just for starting, it was interesting for me to listen to about the guidelines on arterial hypertension with obesity and new Chinese guidelines. And if I understood correctly, that you recommend to start from monotherapy, which is differs from European guidelines, which recommends to start from, in most patients, to start from combined therapy. is it due to different evolution of hypertension in Chinese people and European? That is very slow progression of arterial hypertension until the target organ damage. So it's very interesting to me to listen about it. Which
Yes, we actually recommend the use of combination therapy in those patients with stage 2 hypertension or stage 1 hypertension plus higher cardiovascular risk. Only in those patients with stage 1 hypertension, monotherapy can still be used for the initial therapy. So most of patients, if they have high blood pressure or high cardiovascular risk, they would be treated already with combination therapy at the initial stage. We to this monotherapy option for patients mainly because in stage 1 hypertension, there is no real urgency to start combination therapy immediately after diagnosis, because many of them actually even have to implement lifestyle modifications for a few weeks. So I think it's probably more realistic to start with monotherapy. And then, of course, if blood pressure is not controlled to the target, then a combination therapy should be started as soon as possible. So that's our recommendations on the choice of either therapy or combination therapy.
Okay, thank you. And my suggestion to write a consensus about differences on evolution of blood hypertension in Asian population and European population, as it was done for nocturnal hypertension, is my suggestion.
Yeah, very good
Also,
idea.
Yes, to think, and also about time to in targets. For my question, how often we need to make blood pressure monitoring per year to learn fully about time in range of blood pressure? 2 times a year or 3 times a year? Yang Li, Professor Yang Li. It's my question to Yang Li.
Yeah, I think Professor Yan Li is not online. Maybe Ji-Guang can answer the question.
Yeah, actually, we did not recommend any frequency for blood pressure measurement, typically for the evaluation of time in target range. But I think blood pressure should be measured more frequently in fatal hypertension. So it means that not certainly not 2 or 3 times a year, but should be at least in a community health center. Normally, blood pressure is measured every month. So it means that at least they would have 12 measurements a year, so you can calculate time in target range from those 12 measurements. So that's probably for clinical blood pressure. But of course, if a patient measures blood pressure at home target the time in target range for home blood pressure can also be calculated, and home blood pressure is usually more frequently measured almost every day or every other day. So probably that's the best option
for the evaluation of time in target range instead of clinical blood pressure measurements.
Yes, thank you, Jiguang. Professor Yu King, do you have any comments?
No, I don't have any other comments, because I think the time of is up, and we have to stop here.
Okay, thank you very much for all speakers, for chairman, for all attendees. It was very interesting meeting. We learned a lot about the situation in China, but I do not see a lot of obese patients in China. A lot of people with China. Maybe something happened. Because I was before pandemic, I didn't see a lot of people, Chinese people, obese. Maybe something happened after pandemic, because you told that obesity is rising in China.
Yes, it's rating about 16% of the patients have obesity, but another maybe 36% are overweight, or roughly about 50% of the population, adult population, obese and or overweight. So, but quite different 40 years ago. So great change. Even in Japan, the rate of prevalence of obesity is also increasing. That's the big problem in the East Asia region.
Okay, thank you. So I would like to say goodbye and thanks for everybody attending, and hope to see you in nearest future. Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.
Bye-bye.
Bye-bye.